Our speaker today is known as one of the premier thinkers in the field of development. He has been able to work through incredibly complex issues, creating levels of understanding that are essential for policymakers and healthcare implementers alike. Dr. Kremer is a fellow at the American Academy of Arts and Sciences, a recipient of a MacArthur Fellowship and a Presidential Faculty Fellowship, and has been named a Young Global Leader by the World Economic Forum. In addition to his post at Harvard, Dr. Kremer is the Scientific Director for the Development Innovations Venture Division of USAID, a Senior Fellow at the Brookings Institution, and a Research Associate at the National Bureau of Economic Research. Throughout his illustrious career, he has published over 100 articles. However, it is not just the breadth of his understanding that has been invaluable to the field, but also the depth of his research. Dr. Kremer is unparalleled in his ability to observe and identify connections between variables. While studying parasitic worms in East Africa, Dr. Kremer firmly established the presence of positive externalities to good public health practices by showing that whole communities could benefit when only a portion received preventative treatment for these worms. Dr. Kremer challenged previously held beliefs about the efficacy of such healthcare programs. Dr. Kremer has continued his work in public health, examining investment and social norms relating to water rights and sanitation, studying sustainable ways of realizing healthcare policy, and evaluating long-run impacts of surveys on their participants. I think it goes without saying that we can all benefit from his insights into health behavior. Thank you very much for joining us, Dr. Kremer.
Great, thank you very much. So in 1900, US life expectancy was less than 50 years. Today in Vietnam, it's more than 70 years. And that's despite a per capita income of about 1/5 US levels in 1900. So what I think this illustrates is that it's today possible to achieve historically unprecedented levels of health, even at very low levels of income. So the last presentation had a lot of bad news in it. Let me try to lighten the mood a little bit with a little bit of good news. I won't keep it light for too long, however. If you take a look over at the furthest right column, you'll see the life expectancy in sub-Saharan Africa, and you'll see that this is still at these levels, these much lower levels. So if you think about what is it that's made it possible for a country like Vietnam to achieve life expectancy levels that are far above that of the US when it had a similar level of income, it's largely due to the development and widespread use of a series of inexpensive technologies against infectious diseases, things like immunizations, antibiotics. And those have tremendous potential. But it's not automatic that those will necessarily be diffused. It takes a whole series of efforts to do that. The sub-Saharan Africa case shows how it's possible to lag behind, but if you look at the progress that's been made in sub-Saharan Africa in recent years against huge reductions in child mortality, you'll see there's also been improvements there, and they're in more recent, even over the past 5 years since that 2009 figure. While these technologies have made a huge difference, there are many effective health technologies that aren't fully used. So, for example, while vaccines save millions of lives every year, millions still die from vaccine-preventable disease. Malaria kills millions. Mosquito nets, there are many technologies against malaria that have made a lot of progress. Mosquito nets are still not used everywhere that they could be. You think about waterborne disease. Diarrhea is a big killer. It's very, very simple, very cheap to treat this. Just a little bit of chlorine, which is very inexpensive, can kill most of the organisms which cause diarrheal disease. But it's not being done everywhere. So let me show you that overall there's a very strong relationship. So this, by the way, is from using the Gapminder software, which is on the web. If you want to create charts like this, or even somewhat less gaudy ones, they're very, if you have a better sense of design than I do, it's very easy to do it. You can go on the web and create them. But this shows, on the one hand, that there's a very strong relationship between child mortality and income. But on the other hand, if you look at any given income level, you'll see there's a lot of discrepancy in levels of child survival. And that discrepancy indicates the scope for policy. Make a lot of difference in the way that you organize. The governments can make a lot of difference in the way that they organize healthcare delivery. And I say governments, but I think this goes as well to actors beyond governments. So that's sort of a scene setting for why we care. I would also say, I focused on just the basics, and I think that's probably where the focus should be. It's these discrepancies in child survival, discrepancies in life expectancy, those things matter directly for human welfare. You could also discuss, do these things matter for economic variables, for economic growth? I think they do, but for me, the main case is just these variables are important in and of themselves. Be happy on Q&A if people would like to discuss a relationship with economic growth, but to me, that's a somewhat secondary issue. What I'd like to focus on is the question of how do we understand human behavior around these areas, and what can governments do? I'll start with governments, but it does apply to others as well. But I think the key actors are governments in developing countries. What can governments in developing countries do to try to address some of these health problems? Let me just go back here for a second. I think when I say these health programs, let me be a little bit more specific. I'm thinking of the health problems of the poorest countries. So for the very poor countries, if you take the rich countries historically and the very poorest countries now, a big share of their total, what's called the burden of disease, people try to quantify these things and say how many years of life are lost due to various causes. If you look in the United States now, only about 3% of the total burden of disease, treat all these numbers with a big grain of salt, but the people who try and quantify this say only about 3% of the total burden of disease is due to communicable diseases. If you go to the very poorest areas, you get numbers like half of the burden of disease is due to communicable diseases. Those things, there's some very cheap and effective technologies that you can use to address those that can be administered to everybody, like vaccines. When you get to the level of income of the US now, or even to the levels of life expectancy that a country like Vietnam has, then you're in a much more difficult situation. People have things like heart disease. You need to diagnose people individually, design personalized treatment. That's much more complicated to get the big improvements in health at very low cost. Those are real problems, obviously, but I'm going to focus on the opportunities for quick wins, at least at the start of the talk. So there are two areas. One that I think we've grown to understand a lot better over the past 20 years or so, which is on the consumer behavior side, both about prevention and on the treatment side. The other area, and we still have a lot to learn about consumer behavior, but the other area is about healthcare provision, the behavior of healthcare workers, for example. That's an area where there are big problems, and I think we have a lot to learn. Some promising areas of research, but a lot more to find out. So let me frame some of the discussion on consumer behavior around a policy debate. And that's a policy debate about cost recovery. So one view is that it makes sense to charge the poor, to just charge people in general something for their health care. Maybe not the full cost, but to charge something. And the argument there is that the poor can pay at least some fees, and that they in fact do pay that. So if you look at the price paid for water, somebody living in an urban slum pays much more for their water than somebody living in a rich neighborhood in the developed world. Why? They don't have water infrastructure installed. They have to buy their water, and they're paying more per liter than, say, I would be paying in my Boston suburb. Second argument is that if you don't charge somebody for something, they may not value it, and then they may not use it. So charging gets people to place a value on something. The third, I'm not necessarily endorsing these arguments, I'm just sort of listing them. I think these tended to be quite ideological disputes, and I think we now have some evidence on some of these. The third argument was that if you want programs to be sustainable and if you want to motivate providers, it's very important to charge. So that's not really an argument about consumer behavior, more about provider behavior. On the other hand, the critics of user fees argue that it reduces access, and they argue it reduces access particularly among the poor. So what's happened often is that you get a compromise worked out of some sort. So a typical compromise would say, okay, we'll have some fees, but we're going to keep them small, and maybe we'll have some exemption for the poor. But these compromises tend to vary a lot by sector. So for example, I don't even say compromises, the outcome of this sort of fight between these two forces varies a lot by sector. As far as I can see, not with much rhyme and reason, although maybe if they're political scientists will be able to shed light on why it varies. So if you think about vaccination, pretty much everywhere in the developing world, or outside of the US really, vaccines are typically free. So there, the debates come down pretty heavily on the side of free provision. On the other hand, in water, which is an area I work on, there's sort of a very widespread view that it's important to charge for water, and there, free provision is much less common, at least for improved infrastructure. As I mentioned, this debate tends to be very ideological. Until recently, I think the evidence on this was weak, but I think since about 1995, there's been a wave of randomized evaluations. And I think cumulatively, those are really starting to build up answers to some of, not all of these questions, but to some of these questions. And of course, there's a question of, are these results generalizable? Can you take the results from one study in Nepal and say things are going to go similarly in Brazil? And so one of the things I'll try to do is say, now that we've seen a bunch of these studies, where does there seem to be stronger, where do we seem to be getting results generalizing, and where do they not tend to be generalizing? Let me just say a little bit about, I noted randomized evaluations. How many people here are not familiar with the idea of a randomized evaluation? So randomized evaluation, it's very similar to say in a medical trial. So let me first start out with the problem that they're designed to address. Suppose you're trying to understand, is it better to go to private school or is it better to go to public school? I'll give an education example. Well, you could look at the test scores of kids who went to private schools, look at the test scores of kids who went to public schools, and see what the difference is. Problem with that is different types of kids go to private schools than public schools. So maybe you're not really picking up the impact of the private school, you're picking up the parental background, which types of parents tend to send their kids to private schools. Of course, then you can try and deal with that by saying, well, we're going to try and use some statistical controls for parental income. But then you can say, well, maybe it's not just income, it's also parental attitude. You can say, well, we could try and get survey questions for the parents and control for that. But maybe also different types of kids within the family. Some would tend to get into one school, some into another. Try and control statistically for that. You can see this gets messier and messier, and there's always lots of opportunities for argument. What happens in a randomized trial? So they're very common in medicine. If you want to get a new drug approved, there's a process where there's random assignment to a treatment group and a comparison group. And there are some cases where it's possible to do similar things in other contexts. So to take the education example, often charter schools have lotteries to see who can get in. If they're oversubscribed, they'll have a lottery, and if they have 200 people applying, only 100 slots, they'll have a lottery. And then you can compare the people who won the lottery and those who didn't. And on average, they should be similar, aside from whether they went to the school. And that way you can find out what's the impact of going to that particular charter school. And so there's some cases now where this has been done in various development contexts. And I'll talk about a few examples. Okay. So this is the debate, a policy debate. Let me say a bit about the standard framework that economists would use to look at these questions. So there's something called the health human capital model. So this is a model in which, notice the word capital in there. So this is an idea that Gary Becker had from the University of Chicago. And the idea was that we can think of an investment in education or an investment in health in a way analogously to the way you would think about making another type of investment, say an investment in building a factory. You pay some costs in the short run, but you get some benefits in the long run. So that in the case of education, you pay tuition now, but maybe you'll earn more later, or maybe you get some other benefits other than just the financial ones. In the case of if I brush my teeth today, then maybe I'm less likely to get cavities tomorrow. So in that model, it sounds almost tautological at this stage. But in that model, consumers invest if the expected benefits of this exceed the cost. You'll see that I wrote the word private there. So in the case of some investments, if there's a gain from this investment, the person who pays the money to make the investment gets the gain. If you invest in the stock market or something like that. In the case of a health investment, if I'm investing, say, I'm wearing a seatbelt, well, maybe I'll get most of the gain from that. But if this is a vaccination, if I vaccinate myself, I don't just benefit myself, I benefit everybody else who I don't spread the disease to. So the theory of this is that in the case of communicable diseases, people will not necessarily invest in as much as would be socially desirable to control the disease. And so there's a role for government investment. So that's actually a very Gary Becker's University of Chicago, but so even the most sort of standard orthodox neoclassical economics would say, in the case of externalities, there's a case for government intervention. So I'll talk some about the evidence for this model. But let me just say there's at least some evidence that people do respond to the benefits when they make health decisions. There's an interesting study that a guy named Rob Jensen did in India, where he provided assistance to girls in getting call center jobs, or young women, or I don't know whether they were under 18 or over 18, but people who were just graduating, probably actually young women, in getting call center jobs, and then saw that the parents invested more in girls' health and education if they thought, well, this girl might go on to become earn some money for the household. So in this model, I'm going to have a lot of questions about this model, as you'll see later on, but I don't want to claim there's nothing to it. Okay, so I wanted to at least cite one study suggesting some evidence for that. So in this model, there's not that much rationale for governments to get involved in health. But one of the clear areas because if people are going to invest in that model, people will invest on their own. If the investment's worth it, people will do it. If it's not worth it, they won't do it. Why should we, to be a little bit provocative, in the last discussion there was the idea the government takes some money from you and then spends it on protection. Well, why not cut the government out of that equation and just let people make their own decisions? That would be the standard Chicago view, but they would make an exception for the case of externalities. Okay. So they make a case where externalities where if I do something that helps other people, like immunizations. Now, that generates what they would call a market failure, and that generates a role for government. How much the government should get involved depends on how big that effect is. It depends on how distortionary taxes are, because after all, you have to raise, if you're going to subsidize health, you need to raise the money for that. Taxes are distortionary, so you may not want to do it that much, but that's an open question, and there's formulas you can use to try and quantify that. It also depends on, do people change their behavior that much when you subsidize it? If people aren't going to change their behavior that much, there might not be that much point subsidizing it. So even if you've got a market failure, how big is the case? Really, is there really that big of a case? It depends on a lot of specific circumstances. So I'd like to talk a little bit about an example of a study that I was involved in Kenya. So this is worked with a small NGO. They were initially working in 7 schools. They were actually involved in education rather than in health, but they decided they were going to try something new. They were going to try to administer medicine to help treat kids for worms. So this is things like, how many people have heard of these things? Hookworm, whipworm, roundworm, schistosomiasis. These actually used to be a very big problem in the U.S. South, but they're no longer. There's still some worms in the U.S., and I don't want to say that they're totally disappeared, but they're not nearly the health problem that they were in the U.S. But they're a problem in a lot of developing countries. So approximately 1 out of every 4 people worldwide has worms of some kind. and they're a particular problem for school-age kids. So the NGO thought, well, why not? And they're very, very cheap to treat. Why are they cheap to treat? There's lots of companies that make the medicine to treat them because there's a big market for pets in the U.S. And if you watch TV, you'll see, buy deworming medicine for pets. But there's still 1 billion people, there's still 1 out of every 4 people in the world who has humans who has worms and are not treated. So the NGO was going to introduce this deworming program in schools. They were going to go from working in 7 schools. They were going to add 25 more each year. So they added and they had a plan to go to 75 more schools, and they randomized the order in which they were going to introduce this. Not actually with the random number generator. They put them in alphabetical order, counted off. And we looked at so I was involved in the evaluation with Ted Miguel, who Eric knows, and we looked at the impact on disease. And this was, we were pretty confident that we had seen an improvement in disease. But what we saw was not just the impact on disease, but we saw an impact on school attendance as well. So about 1/4 of the school absence disappeared after the kids were treated. Moreover, we saw this impact not just in the schools that were treated, but we actually saw in the neighboring schools there was also a reduction in worm prevalence. And when we followed this up, it was only certain age groups that were treated. So the program only followed the program only treated kids who were in school. Later, Owen Osier, was he a classmate of yours?
Yeah.
Okay. Owen Osier did a study where he went and looked at the younger cohorts and followed them up later on and saw that they had their health also improved. In fact, their cognition improved because. So what's going on here? Well, worms are a communicable disease. They don't go straight from person to person. They're fecally, orally transmitted. I won't go into more details than that. But they go into the environment, and then people pick this up again through their hands or their feet. And I say fecally, orally. That's diarrheal disease. This is fecal contamination that can go through hands. In some cases, depending on the worm, can go through feet as well. Okay. So that's so when you quantify the benefits, they look very, very large in terms of education and in terms of health. So the second issue, I mentioned several things you'd have to look at. How big are these externalities? Well, it suggests that they're actually quite big. What about the price responsiveness? Well, what we found here was that when the NGO did this for free, there was 75% take-up. There probably actually would have been much higher take-up, but because there was an evaluation going on, they had to get parental permission parental permission for the kids to be treated. So sometimes parents didn't fill out the forms. There were very few outright refusals. When they introduced so the NGO had a policy. They firmly believed, in general, that they should always charge for everything. Many NGOs have that view, and so we were able to convince them to just do that, to not do their normal policy in a subsample of schools. So there was 75% take-up when this was free. There was 18% when there was a small fee. Now, the way their fee worked, it varied a little bit with the size of the family. So it was not a per-child fee, it was a per-family fee. So you got a better deal if there were more kids in your family. There was no differential take-up depending on the size of the family. We also didn't see any evidence that the sicker students were more likely to pay. So it didn't look like it was the people who really needed who were more willing to pay. So based in part on those results, the NGO decided they were going to change their policy and make this free for everybody, which we supported. So that was the initial policy impact. But I mentioned, I think the key player here is not it's great what the NGO was doing. I don't want to diminish that. But an NGO is only going to be able to work in so many schools. I think the key player is the developing country governments. And so the government of Kenya, we were able to present these results to them. They, in the Ministry of Education, and after quite a long and involved process, it's not easy. Policy change is not an easy thing. It took lots of steps. But eventually the Kenyan government introduced this into their national education plan, and they had to talk to the donors because for a lot of African countries, a big share of their funding comes from donors. So with the combination of Kenyan government resources and and donor resources, they were able to launch a national plan. They're treating 5 million kids a year now, and basically in all the areas of Kenya where worms are a problem. And then based in part on that, various Indian state governments saw what was going on. They decided that worms are also a big problem in a lot of India. And they decided they were going to implement programs. And once the first Indian state government did this, then other governments started doing this. So Bihar's now doing this, Rajasthan, Delhi. So it's now there's 40 million kids a year through. I mean, there are other programs, but through the ones that sort of come through this, there's 40 million kids a year being treated. So this, I think, one of the reasons was there was fairly clear, and I think there are a lot of contributing factors, but one of them was there was fairly clear evidence of the impact. I should say I'm actually involved in some follow-up research on this, and we're now following these kids as young adults. So they were maybe fifth graders, sixth graders at the time of the study. We followed them when they're in their 20s, and we saw that the actually quite different results by gender. So for the people who were girls at the time of the study and are now young women, they've gotten more education as a result of this. For the boys, the big impact is on more hours of work. So they're now working about 15% more and earning more. And actually, as if I put on I said I wasn't going to talk too much about the economic impact of this, but when we do this, when you look at the extra earnings, because the medicine's so cheap, what we find is that the extra amount people are earning, if you just look at the extra taxes the Kenyan government's going to collect from the extra amount that they're working, that is enough to pay back the initial cost of the program plus interest. So the Kenyan government actually comes out ahead of this. So for those of you who are into economics, if you've heard of the Laffer curve is the idea that you could cut taxes, and that might actually raise the amount of money coming back to the government. There's not actually a good case of where that's been demonstrated, where there's strong empirical evidence for this. This is the equivalent of an expenditure Laffer curve. It's sort of the opposite, a case where you increase expenditure, and that increase in expenditure actually allows you to cut taxes. And we think we've got a case where you've got an expenditure program that actually generates enough revenue, the government could sort of simultaneously increase the expenditure and cut taxes at the same time, without negatively affecting its budget. So that suggests that I think this is one example, and maybe a particularly dramatic example, but I think there are a lot of cases out there of just extraordinarily good health investments that can be made on purely economic grounds. Even though I said I don't think that's the primary reason we should make these investments, I think there are a bunch of potential investments like that. Okay, let me skip over. I'm running behind badly already, so let me skip over this example. But another case where there's sort of a very orthodox economic case for investment is if there's something that's a public good. So this is an example of spring protection, something in the water sector. Let me go back to this question of the idea that you would want to restrict government role in health to very particular areas comes out of this human capital model, which is a model in which has a lot of assumptions in it. And I don't want to criticize, I think there's a role for making assumptions even if they're not totally accurate. But we have to start somewhere when we model human behavior. But let me try to, you might think this model that says, well, you invest if the benefits, including the non-financial benefits, exceed the costs, including the non-financial costs, how much content is there to that model? Can everything fit into it as a tautology? Let me actually try to look at some of the evidence and see what we find. So we'll first look at issues of how people respond to prices, how they respond to other financial incentives, how they respond to information. So here's something you see in a variety of contexts. I won't go through these, but the behavior that I talked about on worms, where people seem to be very responsive to prices, that seems to be quite general. So there's a bunch of different studies here. Deworming, but also mosquito nets, water disinfectants. So what you see is very small. If you look at the bottom scale, you'll see that these are actually very low levels of prices. Moving from a very low level, even if you start out at a very low level of price, the mosquito nets already start out 90% subsidized in these cases, even at the highest price. Going from that down to zero or a low price leads a lot of people to change their behavior. So, it could well be any one of these studies, I wouldn't say is inconsistent with the idea that people are rationally weighing the benefits and costs. It could just be There's a lot of people for whom it's not worth it to buy a mosquito net at 60 cents, but it is worth it to get a mosquito net if it's free. But that requires a lot of people to be sort of on a knife edge. It's a little bit strange. This seems to show up case after case after case. And so that's a little bit of a clue. Maybe this isn't necessarily the best model of health behavior for preventive goods. Okay? I should stress, this is just preventive health goods. If you think about the policy, so that casts some doubt on the sort of standard model of human behavior used by economists. It also might be relevant for this policy debate, because after all, there's no point subsidizing people if it's not going to affect their behavior. Let me turn to a side issue here, which is, okay, we can get people to get the good, but if you get them to get the good, that's not going to do much good if they say, sure, I'll take the mosquito net, but then they use it for something else. And it's widely believed by practitioners that a lot of NGOs will tell you the worst thing you can do is give something away for free. And there's some theories in psychology that might justify that concern. However, there doesn't seem to be much evidence for it. So a study in Kenya, and another one in Uganda, both found that there was no difference at all in use rates of mosquito nets, depending on whether they were sold or they were given away for free. So a study of water purification in Zambia has similar results. There's some subtleties to that, but I won't go into it in a 40-minute talk. Okay. What about financial incentives? Well, so I'll talk about these as negative prices, but you could also just talk about this as a subsidy. So Mexico, and since Mexico did it, a number of other countries have introduced programs that say, we'll get rid of our traditional income redistribution programs, or what Americans call welfare programs. We're going to get rid of we sort of have a patchwork of different programs. We're going to replace it all with one comprehensive program. It says if you have your kids in school and you get basic medical care for your kids, preventive care and so on, then you'll get what's called a conditional cash transfer. So those have pretty big impacts on health and education. That was found in Mexico and elsewhere. What's a little bit more surprising from the standpoint of economic theory is that actually pretty small incentives actually seem to have pretty big impacts as well. And that's true for whether people are picking up their HIV results. So you might think that picking up your HIV results, that's a very sensitive issue. Are you going to pick up? A lot of people get tested and then never collect their results. You might think, well, that might be they're worried about stigma, they're worried about psychological consequences of finding out that I'm HIV positive. It turns out that actually a small financial incentive, a small difference in the distance you have to go to pick up the results has a huge impact. Okay? So when you're thinking about modeling behavior, some of these things are starting to look somewhat mysterious. You don't see much sensitivity to behavior between a high price and a low price, but then when you move the low price all the way down to zero, suddenly behavior gets very sensitive. A big subsidy has a big impact on people's health behavior, but it turns out even a small subsidy does as well. What's going on here? Well, I think part of the answer lies in some developments that have been taking place at the intersection of psychology and economics. So what had been the standard economic model says that people discount the future. And they discounted at, say, the interest rate, say 10% a year. If you look at the evidence from psychology experiments, it looks like people discount the future, but they do it in a very different way. They have a very high discount rate between now and something in the future. Then it's fairly flat over time thereafter. So that suggests that even a very small upfront cost can really have a very big impact on behavior. Or by the same token, a very small upfront benefit can have a small impact on behavior. So getting people over the hurdle having a small price can really stop people from getting over the hurdle of, say, getting deworming medicine. And that suggests that it may be very important to get rid of those costs if you want to change behavior. Or you can do even better if you introduce a small subsidy. If you've got the money, maybe you go for a large subsidy as well, but that may not always be necessary from the point of view of changing behavior. Let me skip over some things on information. So that's all what I've talked about so far is on the prevention side. If you look at on the acute care and insurance, here you get something that's in some ways quite the opposite till you start thinking about it in terms of this model of psychology and economics. So while there are a lot of prevention investments that are very effective, like vaccination or deworming or treating your water with chlorine, and seem very cheap, and it seems like a little bit of a puzzle, why aren't people doing this? When you look at health treatment, see many people, even very poor people, are spending a lot of money on things that are doubtful, have doubtful impact on health. So if you look at, so for example, in India, there's many public clinics. Most people live quite close to a public clinic, which is supposedly providing free care. But there's huge use of private providers, and these private providers, obviously they're high-end private providers, but aside from the high-end private providers, there's a bunch of very low-end providers who often have no medical training whatsoever, but simply set themselves up providing medical services. And sometimes they get advice from drug sellers, so they'll sometimes prescribe based on that. Sometimes they'll give they'll give antibiotics, whether or not you need the antibiotics, so there may be some health, negative health consequences of this. Sometimes they'll give steroids, so then you feel better in the short run, but it's bad for you in the long run. So why are people spending a lot of money on this? And yet when you offer insurance, there have been a number of programs offering health insurance, and often quite low take-up of this. Again, I think this makes sense from a psychological point of view. If you have if you're suffering from something that you feel immediately right now, then you have a real reason to do something about it, and you're likely to be motivated to do something. And it may not always help. I think you see these same types of things operating out in very different ways if you think about health issues in rich countries. So in rich countries, obviously a big problem is, when I was at the reception earlier, I was definitely eating one of those cookies. Why? It's right in front of me. There's a big short-run benefit of tasting something sweet. The long-run cost to my health, those are not something that, in the moment I'm going to put much weight on. Similarly, if you think about, do people keep taking their prescriptions? Well, many people get prescriptions for blood pressure medicine, for example, and they take it for a while, but they don't keep doing it. Why? It's not necessarily, it takes a little bit of effort to do it, and if the benefits are distant, many people won't do it. Okay. So if you look at, whereas I argued there's very strong evidence that getting rid of prices has a very big impact on prevention, there's much less evidence on this treatment. Okay, there's mixed evidence. So if you think that people are going to, if you think that people act this way, that they're very influenced by short-run costs and benefits, how can we start, what are some implications of that? Well, one implication is maybe we don't want to trust this rational model, and maybe for preventive healthcare, for things like vaccination or deworming, charging might be a mistake, particularly if there are these externalities. And so I think there's been a shift, and you've seen a lot of changes in policy. So mosquito nets are now, for example, delivered much more likely to be delivered free than they were, say, 15 years ago. I think what the challenge is now is to start going beyond this and start thinking, how can we, aside from just saying let's get rid of prices when we can, how can we redesign systems to try to take advantage of what we've learned? So here's a case of on water. Water infrastructure it's often pretty expensive to build that. There's often problems that even if the water is clean when you get it from the well, it gets recontaminated at home. One way to address that is through chlorinating the water. When it's sold, so you can buy these little bottles of chlorine solution. People here will use them when they're going camping. There's pretty low take-up of that. So you can try to design this for free distribution. You can also try to design it to be as convenient as possible. So this is a dispenser. And so people collect, this is a picture taken in Kenya. In Kenya, in a lot of the developing world, people collect water in 20-liter plastic containers. This releases the same amount of the chlorine solution as people would get in one of these bottles that they buy, and it treats the water, and it's right at the well. So basically, when you go to collect your water, you see there's a visual reminder provided by the dispenser, and it's free, so it becomes very, very convenient. And it's also designed to build habit formation because there's a particular time each day when you do it, which is the time you collect your water. And that makes it one of the lessons from public health research and from psychology is it's much easier to do something if you can find a way to help build a habit. So, for example, brushing your teeth. If you're a 6-year-old, it's hard to remember to do that. And it doesn't. But once you're an adult, you're used to doing this. You've developed a habit. And there's a particular time each day that you do it. So this is designed to try to get that. And this took the take-up of water treatment from single digits to roughly half of people doing that, slightly over half. And so there's a whole bunch of, that's an example of, so this is now reaching, I think, almost 1 million people in Kenya and some in Uganda as well, an approach based on this. I think there's a lot that we've learned on the consumer behavior side. I put up several studies, but there's a lot of commonalities across contexts, certainly on the prevention side, suggesting that price plays a very important role. And there's a lot that governments can do, and there's things that NGOs and others can do to address this. The healthcare provision is a much harder topic, and I'll just say a few words on that before closing. So here, there's a real problem that I've sort of, in the first part of the talk, I've made a case for sort of pretty strong government involvement. But second part, I think there's also a case for government involvement, but it's important to recognize that governments are involved right now, and they're doing a pretty terrible job. So this is absence rates in health and education in the public sector in developing countries. So this was a study I was involved in where we just visited clinics, visited schools, and said, is the teacher there, is the health worker there? You could see in health, in the poorest countries, 40% absence. And that's particularly high among in general, it's the most highest ranking providers who are most likely to be absent. So the headmasters in the school more likely to be absent than a regular teacher. In the clinics, that's the doctor who's most likely to be gone, then the nurses, and then the people who are most likely to be there, the very low-ranking workers. Here's some evidence of quality. Very few questions, very short amount of time spent per patient. It's not necessarily that they're crowded. I mean, hospitals will be crowded, but small clinics aren't. And people often go to unqualified providers, like in the India example. So basically, when the public sector provision just isn't operating very well. And I think that while in many developing, take India, for example. India's developed a not great, but an okay system. When they want to distribute free goods to people, they can usually get them out. Some of them disappear and fall off the truck, but a lot of them get through. But when it comes to delivering social services that require human beings to be present and there's a lot of problems, and they're not necessarily working very well. So what are some strategies to address this? I think there are a number of ideas, each of which show some promise. But I think unlike the case of consumer behavior, where we have evidence now from lots of contexts and can start to draw generalizations, I think this is an area where it's a little bit early to be drawing lessons. And I think we need to learn a lot more. Obviously, policymakers need to act as best they can now. So first is the idea of trying to mobilize communities for more accountability. So here's a study in Uganda where they tried to organize the community to better monitor and get results from health services. And they saw a big reduction in provider absence, a big increase in vaccination rates, a big increase in vitamin A results. So while that worked very well, there was another study in India that tried to do similar things in the education sector, and it was an abject failure. What's the difference between these two studies? Well, is it a Uganda versus India difference? Was one program implemented better than the other? At this stage, I don't think we know. I hope over time we'll start to learn better about when these programs work and when they don't. I should note, by the way, that Uganda officially had all of the structures and had a lot of structures in place for community accountability before this program came in, but those weren't working, suggesting that even within Uganda, there's probably differences in the effectiveness of this type of programs. Another approach is just to pay providers more based on measures of outcome. I would say there's mixed evidence on those as well. Another approach, this was tried in Indonesia, where they gave grants to communities, and the communities that improved their health indicators more got more grants. This seems to have worked in getting better health performance, but obviously there might be some equity issues in this as well. You could imagine getting stuck in a trap. There's a poor community, can't improve, doesn't get grants, keeps getting stuck there. Obviously, they tried to do this based on the improvement. It was just one way to deal with it, but in the long run, there might be issues with that. Here's a final approach. This is a study I was involved in. This is a case where Cambodia contracted out some of its healthcare to NGOs. So they sort of let NGOs manage the government health clinics. And that led to big increases in vitamin A coverage, in improvements in prenatal, decreased absence rate among providers. The government spent more on this, but the total health spending actually didn't go up because people were spending less on these unqualified providers. So I feel like this was the program that I wasn't involved in setting up the program, but just in the evaluation. But it looked like this was a big success, but that's one special setting. So I think more work is needed. So those are, let me just say, let me just briefly talk about a few other areas where more work can be needed. One thing is the role of social norms and the role of media. So there's very interesting work on the impact of, say, telenovelas on how that's changing attitudes and how that's, in fact, changing health behavior around reproductive health, for example. A lot of developing countries are now growing very rapidly, and there's a lot of low-hanging fruit of these infectious diseases but there's a lot of potential in South Asia and Africa to move from to increase life expectancy dramatically in some ways that are actually technologically very easy. But longer run, as countries, for middle-income countries, for the Chinas of the world, for the Thailands and Brazils and so on, there's going to be more, and for Ghana and Kenya and so on in the future, there's going to be they're going to have to do a lot more that relies on individual diagnosis, and that means getting these health systems, which are functioning very poorly, to function better. There's also issues around pharmaceutical markets, which I won't talk about. Let me actually link to something that connects to the previous talk, which is the political economy of health. This is very interesting work. If you look in the U.S. historically, the Western states in the U.S. were the first to extend the franchise to women. And you saw that following the extension of the franchise, you saw public health improvements. Why? Because women cared about this, and this was one of the things they voted for. There's a very nice paper in Brazil by Fujiwara suggesting that in Brazil, so Brazil's had mandatory voting. You have to vote in Brazil for everybody, but they had a very complicated voting system, which meant if you were illiterate, it was very hard to, a lot of the ballots were spoiled. They introduced higher tech systems, which made it easier to vote if you were illiterate. There were pictures, it was clear what was going on. They showed that after, Fujiwara's work shows that after that was introduced, government attention and government and outcomes in public clinics improved because the rich people didn't care what was going on in the clinics. They didn't go to those clinics. They went to the private sector. But the poor did care. So more effective voting representation for the poor led to improved health outcomes. Duflo and Chattopadhyay have a nice paper showing what happens when there's reservations of seats. So one of the things that came up in the previous talk was, okay, there are a lot of women in the Rwandan parliament, but is that doing any good? India has a program where they reserved seats in local government for women. And there was a lot of debate, does this really make any difference, or is this just the husbands tell the women which way to vote, and it doesn't really make a difference? And a lot of people thought it was the latter. They actually looked at the data. Because the order in which this was introduced into different villages was random, they were able to look very rigorously at this. And they found that, in fact, there was more spending on water which is an area that women in surveys say they care about a lot, in the villages where seats were reserved for women, suggesting that there's at least some impact of this change in the political process on water, something that matters for health. I don't think they were able to go all the way through to see final health outcomes. So I've emphasized, I've talked a lot about pricing. I think pricing is very important. But I think as we go to the future, as in some very important areas are going to be how do we improve social service delivery, and how do we change culture through media, through other things, and what's the political economy of health, and how do we try and empower people in a way that gets better health outcomes. So, thanks.
I think the students and audience members might have really interesting questions. So Matthew, I'm going to put you around with a microphone, and if you have a question, just please raise your hand.
So you talked a little bit about incentives and how a little bit of push or a little bit more of a push can really have great results. And I was just wondering, how long do you anticipate these pushes to be implemented before people start doing it out of their own accord?
So I guess I just think that I feel like a lot of times in development, people have a view that it's very important that people do their things on their own. I don't do things on my own. I have all sorts of social structures that help support me in doing things that are good for my health. I don't when I wear maybe a good example would be a bike helmet. So maybe this does suggest that there's more complication. There are laws and there's social norms that get people to wear bike helmets. I don't think those things necessarily come in on their own. Maybe after enough time, something does become both a habit and a social norm. But I don't think sometimes that happens, sometimes that doesn't happen. And I think if it's something that is if it's something like vaccinations, I think we ought to subsidize it indefinitely. I don't see a problem with that. That seems just as sustainable. I mean, most countries subsidize vaccinations indefinitely. I think probably if you didn't, it's gotten to the point where, in the U.S., 70% of people, or I don't know what the percentage is. Obviously, in the U.S., it's not necessarily fully subsidized, but you can't enroll your kids in school without it. So it's effectively people are forced by the government to do it. I'm not necessarily saying you should. Obviously, questions about religious exemption, et cetera. But it's made it very easy to do. I don't have a problem with doing that indefinitely if it's necessary. And for some people, I think it will be.
I was just wondering what your response would be to the criticism that randomized control samples for high risk people is unethical in that you should just give people treatment, just give as much treatment as you can afford with your resources.
So I think it's clearly very important to think about the ethical issues involved in any study. So in the case of this, the deworming case that I examined, the NGO had limited resources and they were only going to work in 25 schools the first year. So it was just a matter of which ones those were going to be. And they were pretty close. They didn't have really strong views about where they started working first. It wasn't like they said, well, we know these schools have more severe problem than those schools. So they didn't have much information, and by doing it this way, they were able to find out what worked and what didn't work. And I should say, I focused on some examples of things that worked here, but sometimes you find things that you think are going to work actually don't work. So I think it can be very valuable to learn. What works and what doesn't. But obviously, it's important to think about these issues and to make sure that you design things in such a way. So obviously there are things where randomization isn't appropriate, and I personally would think many of these things should be provided for free in general. But if you've got a situation where they're not being provided for free and an NGO has limited resources, phasing it in over time this way, I think is a reasonable thing to do, and as long as it's gone through the appropriate approvals, both in the country and externally. I think that there are many cases in which this can be designed in such a way that it is appropriate. To take another example, the studies on charter schools, these randomizations are not done for research purposes at all. They're done for fairness purposes because more people apply than the school can accommodate. Or the Indian government example, which I mentioned, they wanted to reserve 1/3 of the seats for women in villages, but they didn't want to introduce it in all villages. They didn't want all villages to be on the same cycle. So when they passed the law to say that this would be the rule, they had staggered introduction. So there are often ways when you get in, there are obviously some cases where you can't do this, you shouldn't do this, but there are often cases where there are ways to do it. Give one final example is sometimes the program is available to everybody, but not everybody's taking it up. So you do extra effort, extra outreach effort to try and encourage people to take that up, and you can target that and there can be some random assignment of that targeting. So often with some careful thought, you can figure out ways, some cases where you shouldn't do it, but often with careful thought, there are ways to do this ethically.
Thank you. Well, one of the things that you had mentioned during the talk was about expenditure referral curves and its implication to the governments in the long run. But then this may be a naive question on politics, but what are some of the things that are preventing those governments from supposedly very logical policies to pursue?
Yeah. I think that's a great question, and certainly the work that the studies that discussed at the end suggest the key role of politics in a lot of this. I think that unfortunately the political the political case for doing something, the political pressures for health are not always the strongest political pressures that the politicians are facing. They have other competing things. I don't. So if you look at the problem of health worker absence, for example, I think the health workers or the teachers are often much better organized and more politically effective than the clients. And the rich clients, the rich parts of the population, I don't want to say rich, even the middle class, they're not using the public systems anyway, so they're not a big lobbying factor. So that's a very difficult political economy problem. Some areas where I do think it's possible to do things are some of these things where there's been a lot of progress and where has to do with charging for basic services, basic preventive services. Often it's quite cheap to get rid of these charges, and there's some political gain for governments in doing this. And as democracies become more widespread, this has been something that's has changed, and I think is a permanent change. So there used to be school fees in much of Africa, for example. At the primary school, that's pretty much gone. And fees for some basic healthcare things are also, the trend seems to be against them. I think that's in part because of some of the evidence of the type that I've discussed, but probably equally or more so due to changes in the spread of democracy.
Matti from Finland, 2 questions. First one, in your presentation, you focused on a lot of experiments concerning on the supply side of things, like supplying this at that price or at this price, supplying at this location or that location. But can you give some examples of experiments where they've looking at demand side things, like why don't people demand enough of this preventable thing or that preventable thing? And a second one, a lot of these research projects, I think Kenya just keeps coming up all the time as a place where these experiments are carried out. So what kind of factors influence which country or location you choose when you do an experiment? Is it the local connections you have there? Is there a dialogue with the country, the government of it, or is it just the interest of the research group itself? Or like, what are the factors that you take into consideration there?
So on the first question of demand, and what are the factors influencing demand? So I skipped over the slide on information programs. I think it's quite a mixed record there, and it's sort of hard to draw generalizations. There's a lot of cases where public health education programs seem to have very limited impact, but then there are some cases where you get fairly big impact. So let me mention one in particular. It's a program that informed, so one of the big risk factors for teenage girls for HIV is sex with older men, and because older men are much more likely to be infected. Turned out, so there's lots of debates about abstinence versus versus condoms, for example. HIV/AIDS education efforts around those may not have that much impact because people already know something about that, and they may have settled beliefs, and they may be very hard to change. I don't want to claim that they're never effective, but at least in one context that I'm familiar with, the impact seemed marginal around that. But it turned out that the girls in this setting, they actually thought that older men were safer and more responsible. I'm not necessarily, by the way, just to be clear, there's a sort of the stereotype of the rich, 45-year-old guy and the 15-year-old girl. That's okay, some cases, but I think much more typical, it's the 22-year-old guy. But at least that 22-year-old guy is he has a job, he's got some money, he's dressed better, he looks more like a grown up. He might, he may seem like a safer partner, but in fact, he's a more dangerous partner. And just providing that information seems to have led to a big reduction in pregnancies and in the rate at which teenage girls became pregnant with older men. So that's an example where demand behaviors did seem to change. But I don't think it's we know the price has a huge difference, but how do you change willingness to behavior through routes other than price? Convenience matters a lot. That's very clear. I guess I tend to put a lot of, I think we know pretty clearly that price and convenience matter a lot. Other things, there are some cases where they do, some cases where they don't, and we need to learn more. And then why Kenya? So I spent a year teaching secondary school in Kenya, and once I had some experience, tended to work with NGOs and the government in the same place, although I've done work elsewhere. But I think now there's research being done of using these types of techniques in many parts of the world. So I don't think it's particularly in Kenya anymore. I mean, Kenya might be slightly overrepresented still, but it's like. Well, how do I make the choice personally? So I tend to talk to both the NGOs and then the government, and to some extent, eventually you have to apply for funding to do these studies because they're expensive to do. But so I think if any of you are interested in doing this type of work, and I encourage you to go to graduate school and so on, but I because I had experience in Kenya and had some sense of, I'm tending to present just the results, but obviously a lot of thinking has to go into these has to be informed by experience on the ground. So if you're from a developing country, then it's great to work in a place that you're familiar with. If you're not, but you've got some experience, then that's a good place to start working. And if not, gaining some experience and then possibly building on that experience. Sometimes, obviously, opportunities come up that you don't expect, and then you can pursue those as well.
So given the magnitude of positive externalities that come from better health services, it seems undisputable that government intervention is extremely essential in low-income countries. However, it seems that, especially in sub-Saharan Africa, not most of it, but an important portion of the budget allocated for health comes from international aid. And recently, due to the global political economy, the Euro crisis and such, there have been attempts to reduce that international aid. And given the elasticity of demand and the low purchasing power, how do you think that would affect the provision of public health services? And how do you think that would affect the economy in general? Or, yeah.
Right. So I guess I'd be pretty concerned about potential negative consequences of that. Obviously, one of the things the governments have to do is they have to think about what, with the limited resources they have available, both the resources they've got domestically and whatever they're able to get internationally, how to spend that most effectively. And I think there's a lot of, unfortunately, I think the procedures to decide how to spend that often, obviously there's straight corruption, but in addition to straight corruption, I think there's a tendency for health ministries to act like bureaucracies do everywhere, and they think about, they do this year's budget the way they did last year's budget. They want to keep they don't want to fire anybody, so they keep their staff salaries, the staff salaries the same, and they keep their staffing totals the same. Often there are things that can be done that might not traditionally fall under the realm of the health ministry, but have big health impacts. So one of them, I talked about water, is one of them, but another one was there's a program in there was so road accidents are actually a major cause of death in a lot of countries, and there's minibuses. I guess you're familiar with those that are they drive very unsafely, and they're just putting up stickers telling the passengers to speak up if they think the driver is driving unsafely. That sort of empowers the passengers to speak up, and that reduces insurance. In the study, they looked at their outcome variable was looking at insurance claims, and they saw that insurance claims involving a death or injury fell dramatically. So I think it's going to be very important for governments to, and it's easy to say this, obviously much more difficult to do this if you're in a health ministry, but to try to think carefully about how they're spending their money and to focus it on the areas that can have the most, so they can get the most health impact out of whatever they're spending. That's not an easy thing to do politically.
I had a question about the element of convenience, and it seems to be an important part of the solution that you're putting forth to provide healthcare within the developing world. And part of why things are convenient is behavioral, and often those things get into culture and habits that are hard to quantify. So I was wondering if you could provide some insight within development as to how economists are dealing with that element of seemingly unquantifiable behavior within the developing world that seems to play such an important part.
Let me give an example from a totally different sector, from the developed world. So one of the things that's about thinking about the future but involves a cost today is savings. So it's really difficult to get people to save, and the U.S. is a undersaving problem, and a lot of individuals in the U.S. seem to have a problem. So it turned out that one of the things and all sorts of things changed in the employer match rate and pension programs and so on. Turned out one of the most effective things you can do is actually also one of the cheapest, which is in the forums when you sign up for a job and you have an opportunity to sign up for the pension program, they just change what's called the default, so that if you don't tick the box, you wind up automatically enrolled in the pension program and they deduct from your salary and you automatically wind up contributing to savings, rather than the other way around, so that you have to tick the box to contribute. Either way, you have free choice, but just changing what's the most convenient is down to ticking a box has a big impact. So I think there are actually probably a number of examples where, if you think about it from the standpoint of human beings are overloaded, we've got constant, so many things to deal with. We don't always have time to think about optimizing every decision, and how do you make it easy to do the right thing? There are all sorts of things in our lives that make it easy to do the right thing. Now almost all employers use this default being that you're automatically enrolled. So if we can try and think, and there's a lot of opportunities to do that in the developed world. I have a regular employer. Most Americans have regular employers. If you're a farmer, as most people are many people are in the poorest countries, then it's hard to have that automatic device. But maybe we can come up with other things. So the chlorine dispenser is a way to try and move this to make it a little bit more automatic. It's still not fully automatic, so I'm sure there'll be better approaches long run.
On the use of price controls for negative externalities, specifically syntaxes on lifestyle habits that promote non-communicable diseases. They raise a lot of revenue here, but people don't like them because they're regressive. And I was wondering what role you think syntaxes might play in the developing world, which are seeing an increasing burden of non-communicable disease.
Yeah. So I think I'm pretty pro syntaxes, I think. So let me talk about, one big issue is cigarette taxes. And I'm not a specialist in this area, but my understanding is that actually if you ask smokers in the U.S., they're actually pretty supportive of cigarette taxes. Why? Because they want to quit, and they figure that actually higher taxes might help them quit. Now, obviously, they do tend to hit the poor. I think the solution to that is to try to make sure that the rest of the tax system and the expenditure system is structured in ways that will try to return some of that money to them. But I think that there's a role to be played for, particularly cigarettes are a very big health issue increasingly big issue in the developing world, particularly as in middle-income countries. On alcohol, I would say that's actually probably relevant for communicable diseases. This doesn't get talked about much. I'm not an HIV specialist, so I'd be curious to hear what people who are think. But I think that alcohol use probably does contribute to spread of HIV, and that there are often alcohol taxes in just as a way of raising revenue on the sort of fancier types of alcohol. But there's illegal underground alcohol that is not taxed because it's very hard to tax. But I think actually trying to maybe crack down on some of the illegal alcohol. Obviously, there are all sorts of problems with that. I don't want to say that there aren't, but and then taxing the legal alcohol, and that might be a way of trying to have some impact on the HIV epidemic. I know what your take is on that.
So I guess the question I have for you is, do we know how these sort of like policy nudges, how do people start to form these habits? What are the good nudges to get people to form healthy habits?
Yeah, I think unfortunately, I think this is an area where we need to know a lot more, and at least I'm not an expert in this area, but I don't feel like we really know. I think that in the case of the dispenser, we're trying to design that so that it would have some of the things that we thought would contribute. So I mentioned that it provides a visual reminder, a visual cue. That can be helpful. So some psychological research suggesting that can be helpful. Obviously, the convenience makes it easier. The fact that it's a particular time each day. It's also something that's public. So that may make it easier in that if you have we actually talked to people about, well, why aren't you chlorinating your water? And I think one of the issues was price, but another issue was, I'm not quite sure how to do it. Well, if you're collecting your water at the well or the spring, and other people are ahead of you in line, and you see somebody do it, you can sort of ask them questions about it. It's also the case, could create a social norm. Other people see whether you're doing it, and that potentially could have a positive effect.
A little bit harder with condom use, maybe.
That's totally true. Yeah.
Was there a question?
I think that's a really hard one.
Yeah. Was there a question over here?
Yes. I was wondering, in your experience, are certain NGOs or international aid organizations more effective at addressing these problems than others? And if so, what do you attribute that to?
Yeah, that's a great question. So I think there's a lot of variation. I don't have a great theory of what I attribute it to, unfortunately. Here's one generalization. Some of the best ones, I think, are ones from, so there's some very good South Asian ones that are now working outside. So I think very good one is BRAC, the Bangladesh Rural Advancement Committee, and they're now working outside of Bangladesh. And I think maybe one of the reasons they do a good job is because they have a good sense of what life is like in a developing country that sort of permeates the organization. I don't mean to be down on NGOs from the developed world. I'm sure there are a lot of good ones. Technoserve is an NGO that I don't claim to know it very well, but the little bit I know of it seems to be doing an excellent job. I do think that one thing that's important, this isn't enough by itself, is being very grounded in what life's really like in the developing world and not having unrealistic expectations and overly romanticizing things, for example, or for that matter, being overly cynical, because you can make that mistake too, is important. But another thing is just the amount of money that's paid on administration is and I don't necessarily mean fundraising. It's just there's often a lot of money goes into setting up the bureaucracies and administering them. There's an NGO, I don't claim to know them too well, but something called Give Direct, which just transfers the cash directly to people in developing countries. I think there's certainly a lot worse things that you can do than that. It's probably a pretty decent place to, if you're looking to donate money, there's probably a lot worse things you can do than give to Give Direct.
One of the things I found really interesting in your presentation was with regards to inadequate public sector dealing with healthcare. And you mentioned the example of Cambodia where they outsourced healthcare to NGOs with some success. And I would just want to ask, how feasible would that be for other countries and possibly as a long-term solution towards tackling some of these healthcare issues?
This is something that's very, if you think as Americans, we think, who has a socialist healthcare system? The UK has a socialist healthcare system, we think. If you look at the UK's National Health Service, the way it works, primary healthcare physicians, they're not actually government employees. They're contractors. They get paid, the government pays them for every person who signs up for them to be their primary healthcare worker. So if you look at, they're actually operating on a contract model. The government's paying, but they're not operating as, through a top-down government bureaucracy. There's actually a market force working there. If you're a primary healthcare physician and you treat all your patients terribly, well, maybe they switch and register with somebody else instead. If you look at how developing country systems work, they're often literally structured as this sort of top-down bureaucracies with the healthcare workers as government employees. So trying to think about how, in general, I'm pretty sympathetic to the idea the government should pay for things, but that doesn't necessarily mean it has to be the only provider. You could have competition among multiple providers, and there are problems with competition. I mean, these are very tough issues, but you could have competition among multiple providers with the government, footing actually doing the financing. And I think that's an interesting model to explore for the future.
When you talked about the impact of pricing on uptake, I wonder if any of these studies showed if there's a differentiation by economic strata. So if a high-income family is just as unlikely to take up or more likely, logic would suggest that higher-income people would be willing, if it's a very small fee, would be willing to pay it, whereas lower-income people would not. That would have a lot of implications in terms of what you do as the economy grows, sustainability, and other things. And do we have information on that?
So I think at the broad macro level, the patterns have got to be, the ones that you suggest. In some of these micro studies, in my own work, I'm actually struck often at how weak the relationship is. If you take the deworming examples or the water examples, it's not as simple. This is in general, most people, there's nobody who's really rich who's living in these rural, very, very few people who are rich. I mean, negligible from a statistical standpoint. We're living in these rural areas where these samples were taken. But there isn't a super strong correlation. I think, and if I look at my own health behavior, I think there are a lot of things. I should probably take an aspirin. I'm probably old enough now. I should take an aspirin every day. Although I guess the advice changes on that every few months or something. But I don't do that. It's clearly not the money that's stopping me from doing it. I'm just not able to get myself organized enough to do it. I think so. Income's definitely a factor, but I think. I'm much more likely to sanitize my hands if there's one of those dispensers out. Where I work, there's one of those. So I think for everybody, independent of income, making it as convenient as possible, which includes making it free, helps. Now, there's budget constraints that matter. You can't. Some things are too expensive to make it for free, and they don't have enough health impact, or they don't have the externality impact. They're just purely for the individual. And if you're a government, you have to make some tough choices. So I'm not arguing against some sort of cost-effectiveness analysis, and certainly there might be some, I think there's often a case for focusing on the poor, but it's expensive often to target to the poor. So for some things, say the vaccinations, I would just say, let's make it free. We're not going to say, okay, only for the poor, and we'll let the rich take care of it themselves, because there aren't that many rich, and they won't necessarily take care of it themselves.
Yeah, I just had a quick question in terms of when you were answering one of the other students' questions. You mentioned the necessary need for outreach in terms of spreading awareness of the low cost, low priced services, and so and I was just curious to know is that if so, what kinds of approaches specifically in the works you've done were these outreach efforts made through? And so specifically with these efforts, was there usually a guaranteed positive response from the consumers? Just a general question.
So you're talking about, could you repeat the question again?
Yeah, okay, I'll repeat it. I wrote it down. So, okay, I'll just start from. So you emphasize the importance of subsidizing services in developing countries, and how there are causes where the cases where these services aren't necessarily taken advantage of because people may not be aware of these services, even though the incentives of low prices are available. Right. Is this because people just aren't aware of these services, that they exist, or even with the low prices, no motivation to pursue these services are in play? And so what kind of approaches specifically from the works you have done were taken for outreach? And with these efforts of outreach, was there always a guaranteed positive response from consumers?
Right. So this is something that's true not just in developing countries, but in developed countries as well. There are a lot of cases where people aren't taking advantage of things that seem like really good deals for them. So in the case of these employer matches, there are people who are at a certain age, you can, if you're 60 and a half or something, you can contribute. Your employer matches, you can take it out the next day. So you get 100%, you get your money matched and you get it back overnight. And why would you not do it? And yet a number of people don't do it. So is response guaranteed when you try to promote these things? No, even then it's not. What are cases of where you try to promote something and it can be effective? Let me give an example. This is a mixed blessing, but in Bangladesh, the government, there's a big diarrheal disease problem. The government encouraged people to dig wells to get cleaner water, and then a lot of people just dug wells on their own. The thing about Bangladesh is you don't have to dig very deep to get water. It's a very wet place. So then it turned out the ground was contaminated with arsenic, not from industrial pollution. It's just naturally there's arsenic. And so then they were worried people are drinking arsenic-contaminated water. So one thing that the government did was it went and tested for arsenic, painted the ones that were pretty safe green and the ones that were more dangerous red. That turned out to have a very big impact, and providing people with that information really led people to reduce use of the arsenic-contaminated water. Problem then is how do you then also address the diarrheal disease problem, and there's work going on how to do that. But that's an example. I mentioned sometimes the behavioral techniques, trying to change behavior works, and sometimes it doesn't. That seemed to be pretty effective. Turned out when they put more detailed information on about exact arsenic counts, that actually didn't work as well. People needed a very simple, clear message of green or red, and that worked better.
And so my question to you, Professor Kremer, is that students here who maybe have some ideas about sort of solving global health issues, and they have that sort of social entrepreneurship bent, where could they take these ideas? Where could they maybe think about either getting feedback or getting funding? I think in your biography, you've been sort of advising USAID. Are there opportunities there? Or what sort of advice would you give to a student in the audience? They have a great idea and they want to see if they can sort of take this idea to the real world.
Sure. Well, as when we were talking before, this Development Innovation Ventures came up. So if you go to the USAID website and you search for something called Development Innovation Ventures, you'll see a program there that perhaps some people would like to apply for. Let me say a little bit about the program. So this has funding to support the piloting, rigorous testing, and then scaling of the most successful of ideas for development. There's a lot of rules about what they're looking for. So I would definitely, if you do look at this, I would look really carefully at what the rules are. It's a very competitive process. I mean, there's I think it's less than 5% of proposals are accepted right now. So I don't want to make it sound like it's easy, but certainly we encourage people to take a look and to apply. In terms of you mentioned both funding, and there are obviously lots of other sources. I think that generally I would also take a look at some of the groups that won. So it's typically going to require some track record before you can get to the point where you're able to be eligible for funding. But some of you may be at that stage, or may be able to get to that stage. So I lost my train. Oh, the other thing you asked about was advice. So one thing is that they're not. If you do apply and you get turned down, depending on how far you got, you may be able to ask for they send it out to reviewers, and the reviewers look at it, and then there's committees that meet, and you can find out the reasons, and maybe you'll find some of that advice to be useful. They can't give you advice in advance because of various procurement reasons. So you can't go to them and say, do you think this project would be potentially eligible? Unfortunately, they're not able to really answer questions like that, sort of government procurement rules. But if you do apply, and if you get funded, then that's a good signal. And if you don't get funded, you might be able to find out more about why, and you might be able to get some advice from that process. I guess I would just say it's great to hear how many people are interested in global health issues and in social entrepreneurship. I spent a lot of time saying some cases where he didn't think it makes sense to charge. But of course, if you're an NGO and you've got to support yourself as an NGO and you feel that there is some sector where you can get cost recovery, then I'm not saying, take the example of water treatment. I think governments should provide that for free, but as long as they're not doing that, there's an NGO called PSI, which is trying to get cost recovery for that, and they are reaching, they're reaching a lot of people, and only a small fraction of the number that could be reached if it was for free. But I don't mean to sound negative on efforts that are doing this on a more of a commercial basis. So I think there's also scope for doing things that way. And yes, it's great to hear so many people are interested, and I encourage you to keep looking for opportunities to continue this. Thanks.
Great, thank you.